Good afternoon all, and welcome to the next lecture, which is going to be given by Kemi. She is just realized I was muted. Sorry. Yeah. So let's lecture be given by Kemi Ajuamafor. She's one of the nurses here at Thousand St Thomas's, and she's going to be doing a little lecture on the role of community sickle cell nursing. And I hope you enjoy. Kemi, you can go ahead.
Thank you. Good afternoon, everybody. Like Ola said, I'm one of the nurses that look after children and adults with sickle cell and thalassemia in Southeast London. Our center is the biggest center in the whole of the UK, and we cover, this is where we cover, this is our local population that we cover is quite huge. And we see them antenatally from cradle to grave. And we offer them a lot of services. Some of the services that we offer is genetic counseling, also preconception counseling as well for couples who are at risk or just want to find out what their genotype is. And we will do the test and give them the result, and that will inform their decision whether to carry on getting married or not. And in terms of genetic counseling, these are for women who are already pregnant and identify from the lab to be at risk. So what we tend to do is we give them a call. Once we receive the result from the lab, we make a pack, we give them a call and offer them appointment for genetic counseling and testing of baby's biological father. We don't say partners, we use baby's biological father because they might have a partner and they have a husband. So it might be one of the two that make them pregnant. So we use baby's biological father. Again, we also give timely blood screening results to patients. We look after our caseload. Everybody has a caseload. My caseload is pediatric caseload from 0 to 18 years of age, as well as I'm also a genetic counselor. And so I see them antenatally. So we manage their disease and we support the individual to self-manage themselves, to self-manage their condition, and we offer health promotions in the community as well as to groups of people maybe in the church, mosque, as well as school as well. We offer training for other healthcare professionals like school nurses, health visitors, and whoever cares to listen. And like I mentioned earlier on, we also offer pre-conceptual screening and counseling for general public. We also provide education and training program for the public. This is in snapshot. This is what we do. This is part of our role. I've mentioned some earlier. We offer hospital visits. For instance, if one of our patients is in the hospital, we can go to the hospital and see them and find out what is happening. And if the nurses on the ward does not know how to look after them, we give them the answer, and we work alongside the acute CNSs, which is the clinical nurse specialists and the hospital doctors. Referral to other multi-agencies, for instance, housing and social services and voluntary organization. We do this a lot of the time because most of our patients, because it's a long-term medical condition and it affects people differently, some of our patients are not able to walk, so they need help to claim for benefits, as well as maybe housing, and it's part of our role to write them a statement or supporting letters for their housing, as well as for their assist them in completing their forms for housing and benefit that they can have. We also do give general advice, information, and we raise awareness. We do this from time to time. Oftentimes, I've received phone calls all over the world calling me for some answers, and particularly when some of our patients go abroad and they happen to have crises. If the hospital is not very sure how to look after them, they call us and we're able to speak to them. I had a call from Uganda last week for somebody who wants to know about bone marrow transplant. So you can see I get calls all over the world, and we're happy to answer any questions or concerns you might have. We also run support groups. We do support groups for children, mainly babies during the week, as well as adults in the hospital, but the babies are done by us, the community nurses, and we run that once a month from the month of March to the month of October. The reason why that is because from October up to February is very cold, and we don't want them to come out in the cold. Hence, we do it March to October, once a month. So if you want to join our support group with the next one, you're happy to join us to see what we do. We invite various speakers, sometimes the doctors, the nurses, research nurses, to come and speak to the parent to know what is new in research and whatever new information that we have, and as well as pairing mothers together, because some moms are more experienced than other moms. So we pair them together if they are having difficulty accepting the diagnosis. We pair them to other parents that can be their mentor. So if they are not sure of anything, they can always call that person and the person will give them a crying shoulder. So these are the things we do. We work in partnership with health professionals and voluntary organizations such as Sickle Cell Society, UK Thalassemia, as well as STAMMAP. STAMMAP is the Association of Nurse Midwife and Allied Professionals. So I'm one of the executive member, I'm the treasurer. We have a chair, so if you want to join us, you can as well look on the website. It's STAMMAP, STANMAP. And you can see more information there. And what we are using this is like, we want to bring everybody all over the world together to make sure that we are giving the same or similar information, care and management, and anything new, because some countries might have new research or new medication that we here in the UK don't know about. So when we meet twice a year, and the joining fee is £25 yearly. So you'll be able to access any information required and meet other healthcare professions in the field of sickle and thalassemia. We go to clinics. Part of my role is attending clinics as well. So what happened is, our clinic is on Fridays here for pediatrics. So I try as much as possible to go to the clinic, because some of the patients, particularly the new ones, they know me already and they feel very scared going to the hospital for the first time and seeing a lot of people, they get scared. So I try to be there on their first appointment to introduce them to the team and support them however they want me to support them. So we see them in the clinic, and we also perform home visits. Our home visit is, it depends on your diary. Everybody's day-to-day role is different. For instance, today is different from what I did yesterday. Yeah, today I'm in a clinic. I just seen antenatal couples and so on. But yesterday I was busy doing something else. So my role from day to day varies, because you can see that I cover a lot of duties in a week. So you can just prioritize what you want. So home visit is one of the most important things that we offer. And when we go to see them at home, we just want to make sure that they are coping very well at home. We go through the care management and as well as medication and as well as any support that they need. We also sometimes go there to assess the house that they live in order for us to be able to support them with their housing letter, so that with the letter, they will be able to be given conducive accommodation. And like I said again, we also try to facilitate the care management of adults and children with sickle cell, thalassemia, and other hemoglobinopathies. We support and advise families and carers of patients with hemoglobinopathies. Sometimes you become part of their family, because from 0 to 18 months, I've been in this trust now for 8 years. So some of them, I know them from my previous trust, and they are coming here again. So I've known them for like 15, 13, 20 years. So it's like you become part of the family. You see them growing up from baby to adults, going to university, and sometimes having baby. And that is really, really rewarding when you see that, oh, I've been the journey, I've been part of their journey. So this is really, really nice. We also try to significantly reduce the admission rate and increase patient coping strategies in the community. And what this entails is we try as much as possible to make contact with the patient. For instance, if they are going into crisis, most parents, particularly the younger ones, because it's very difficult and new for most parents to think, oh, is he or is she having crisis? So they phone us first, oh, she's been very irritable, she's been running temperature, and we tell them, have you done this? Have you given pain relief? Is she wet? Is she cold? And so on. And if the parents say they've done that, they've given paracetamol or Calpol to reduce the pain, but nothing is happening, we tell them to take the child to the hospital. But most of the time, some of them give us a call, but most experienced parents, they don't need to give us a call because they know exactly when to take the child to the hospital. So we get called from time to time doing that, yeah? Again, like I said, home visits to assess physical health and social needs of individuals with hemoglobinopathies. Home visit post-discharge from hospital, if indicated. Again, we see our patient at home following discharge from hospital. And we just want to go and make sure that they are fine. And in adults, we go home to do their observations like blood pressure, temperature, pulse, and all that to make sure that they are well enough. And if you feel they are still not well enough and you are not very sure or happy about what you are seeing, you can as well send them back to the hospital. So we see them from discharge to make sure that they are doing well and well supported at home. I've mentioned support with housing application. Poor housing, can impact negatively on their health. And group teaching events, schools, hostels, nursing students, and so on, like what we are doing today. We do a lot of this from time to time. So this is part and parcel of our role to raise awareness in the community. And pain management at home. We try to help them to reduce the frequent hospital admissions. And during events, we try to raise awareness about sickle cell disease and thalassemia in the community by, we've done this many times in the past, but since COVID, we've not been able to do some of what we normally do. We split ourselves, we know the area we are going, and we split ourselves, particularly the area where there's pandemic of sickle cell. We know exactly where to go, and we just go maybe in the barber shop, salon, restaurant where people with ethnic minority are, and then we go and raise awareness and even invite them to come and have that blood test done if they have not done it in the past. Again, we chase up DNA hospital appointment because this is a huge burden on NHS, on the National Health Service here in the UK. And at the same time, we can't really blame our patient client group because Sickle cell is an individual thing and it affects people differently. One minute they might be fine, next minute they are not. So the My DNA, the hospital appointment, and some of them, the DNA for no reasons, though I can't just be bothered. So we chase them up. Sometimes we go home if we've given them a couple of appointments and we've tried to call them to leave them a voicemail and we are not getting any feedback from them. So we do unannounced home visits to make sure they are fine and ask why they didn't turn up for their appointment, and we try and liaise with the hospital to arrange a further appointment for them. Again, genetic counseling and preconception counseling. We also liaise with social services, occupational therapists, housing officers, and we stand as advocates for our service users, our clients. We take blood sample to screen partners antenatally, and we attend joint obstetric clinic. This is one of our major role as well. We attend joint obstetric clinic. We have different joint clinic that we have with the specialist clinic. We have joint obstetric clinic where the obstetrician and the hematologist plus the community nurses, clinical nurse and the hospital clinical nurse, we see these pregnant women monthly, is once a month, and they will decide on the plan of care and what they need to know and what they need to have during pregnancy to support them and reduce anxiety and crisis. We also do joint renal clinic with the kidney doctors as well as the consultants. We do joint neuro clinic. We do joint endocrine clinic and joint respiratory clinic. So these are the clinics that we attend, and all of this clinic, apart from the follow-up care in the hospital, is once a month. But the follow-up care in the hospital, our clinic is every Friday, but we see them every 6 monthly or 3 to 4 monthly, depending on what is happening and why they need to come in more frequently than others. We also enable people to feel in control and contribute to their own overall outcome. This is very important, and we try to teach them this from young, like taking charge of taking their medication, looking after themselves, know what triggers their crises, know what they need to know about by dressing appropriately for the weather, taking their medication regularly. And when they get to about 16 years, from 13 years of age, we do see them from time to time, talking to them about transitioning to adults. And when they get to 16 to 18 years of age, we move them from pediatric to adult from 18 years of age, but we start preparing them from about 13, 14 years of age before we transition them around 18 years, just before they go into university. And we encourage them as well that when they go to university, this is what we've been planning from maybe 4 or 5 years before, like taking charge of themselves, making sure they eat healthily, making sure they dress appropriately for the weather, and as well as making sure they take their medication as prescribed. And overall, our role is about long-term behavioral change to help individuals resume control and to regain their quality of life. So when we go home to see them, these are the things we discuss with them. They are staying healthy checklist. So we discuss tips and advice, managing pain. We have a pain ladder, and they know when to go into the hospital. I've already taken my paracetamol, I've taken my ibuprofen or diazepam, but I'm still in a lot of pain. The next pain ladder for me maybe is morphine. So they know how to take their medicine and when to seek help. Looking after themselves, suitable clothing, balance between activity and relaxation, getting a balanced diet, healthy snack and rehydration, and protecting their health, relevant necessary routine vaccinations. We make sure we discuss that from time to time and encourage them to have that. Here in the community, we have 3 different levels of care. As a case manager, it is a key strand of the Department of Health model for caring for people with long-term medical condition. And level 3 is the complex needs. This involves individuals with highly complex needs who need frequent hospital monitoring. For instance, the new births, the new babies. They see them every 3 to 4 monthly until they're about 2 years of age, when it now goes down to every 6 months, which is now twice a year. And then sickle cell patients in pregnancy, we have to make sure that they are in the pathway. Are they already being seen at the joint obstetric clinic, or are they being referred already? I see them from time to time. This week alone, I've seen 2 women that have referred to the joint obstetric clinic so that they have the necessary care package for them. And again, A&E attendees, they are the ones with the level of level 3 complex need and frequent hospital admissions and non-compliance with their treatment, their medication, as well as not coming to the hospital. Level 2 is client with moderate needs. This individual with complex medical or social needs, like people removal in, that is, they are changing home. They are moving from one borough to the other. So we need to know that, oh, they are now in our borough and we can visit them at home. So from the borough where they are moving from, the nurse needs to give us a call or send a referral to us to say, oh, so and so is coming to your side. Can you perform a home visit, so that we can plug them into the system? So we have that for children and adults with sickle cell, and we can refer them to the hospital where they are comfortable with. Again, clients with disease modifying treatment for raised or abnormal transcranial Dopplers and long-standing ulcers. We don't really see some of that, like leg ulcers in children. This is more in adult side, but the transcranial Dopplers, we normally see that with children between 2 years of age and 16 years of age, because that's when they do the transcranial Dopplers. And to check for blood velocity to the brain and to see if they are at risk of developing stroke, or has had ischemic stroke or is going to have stroke. So we support the parents with that. And clients on hydroxycarbamide are the ones on the level 2 care. Children or adults with blood transfusion and with complex psychosocial and social issues. Because you see some families, they have issues that they have to have social worker, they have to have early help. So those are the ones that are on level 2, and we see them alongside, and we attend joint child in need meeting or team around child meeting from time to time to see how we can support this family. And level 1 are for patients who are self-caring and they are able to manage themselves well. They are stable individuals. We empower them by community specialist nurses to manage their illness through living, healthy living, health promotion, and awareness of their chronic illness. These are the ones that we don't really see regularly, but we still have them. We see them in the clinic, maybe in passing, or they phone to say, oh, I haven't heard from you for a while now, are you okay? And so on. Yes, those are the ones, but we don't really see them regularly compared to level 3 and level 2. So genetic counseling is a very integral part of community nurses' role. For you to be able to do genetic counseling, you must have gone for extra training. So I'm a certified genetic counselor, and I had my training at King's College London. And as for our service, we provide specialist genetic counseling to support the antenatal population booked at Guy's and St. Thomas's, King's College Hospital, Lewisham Hospital, as well as Queen Elizabeth Hospital. So we look after 4 hospitals, 4 big hospitals in Southeast London. We provide effective and acceptable follow-up for those undergoing prenatal diagnosis. We ensure effective and acceptable follow-up, care and support for affected infants and carers. We ensure an appropriate level of understanding about screening and these conditions among professionals involved in the program to allow the effective and sensitive delivery of the screening program to the population in general. We provide expert genetic counseling to support the antenatal population booked in this hospital I've mentioned, and to provide timely expert counseling for women, couples with high-risk pregnancies. So this is the algorithm for how we are able to know that this family or this couple are at risk of having a child. So all women here in the UK are tested for antenatal sickle cell and thalassemia at booking. And if the result is A+A, then we don't need to do anything. The lab will not send them to us. But if they are carrier of unusual hemoglobin, for instance, they are sickle cell S carrier or beta thalassemia, the result comes to us directly from the lab. And we will call them, make a pack for them, call them and book an appointment on the phone. In the past, we would just send appointment letters, but we realized that we might give 20 appointments in a day and only one turn up. So what we tend to do now is we give them a call first and agree on the date and time with them, and then send out an appointment letter so that they will be able to know where they are coming from. And then we'll see them antenatally. And once we see them, we test baby's biological father, and then we wait for the result. Usually the result come back within a week, and then depending on the result, if the result is fine, is negative, A+A, then we don't do anything. But if the baby's father is also identified as unusual variant, then we might offer them prenatal diagnosis testing. And that one is done in this country between 11 to 20 weeks gestation. And once they perform that, we get the result within 7 working days. And we have to give the result to the parent within 5 working days of receiving their result, as well as the newborn screening result is the national guidelines that we give them the result within 5 working days. The parents must be aware. So this is what the algorithm looks like, and this is what we follow. If the woman is disease status is SS or SSC, like I mentioned earlier on, they come through us, we give them appointment to test baby's biological father if they've not been tested before, and then we refer them to the acute joint obstetric clinic, as well as the hospital nurses. Okay, so this is another one that we do. This one, I'm not going to go into it as much, but this is the list that will follow from the screening coordinator and the midwife to us, the GP, and the hospital. This is another one. So this is for women and partner that attended genetic counseling appointment and they are found to be at risk. So we offer them PND. We send the referral to the hospital that they are booked to have the baby. And CVS is performed, CVS or amniocentesis is performed, and we get the result. And we have to give them the result within 5 working days, face-to-face or telephone contact. Depending on what the result is, if the result is baby not affected, then we don't do anything, and baby will be tested via the newborn screening. It's a national program. Every baby born in the UK are tested between day 5 and day 8. And if the baby is affected, then it's the choice of the couple or the parent to decide whether they want to continue with the pregnancy or they want to terminate the pregnancy. Whichever way they end up, we support them to do that. Okay. And we refer them to the hospital, we refer them back to the hospital where they can perform the termination of pregnancy if they want to. But if they want to continue with the pregnancy, then we will support them to do that as well. Yeah, newborn screening. Again, like we receive antenatal screening blood from the lab, is the same way that we receive newborn screening results for babies affected. So we received the newborn screening result from the Regional Infant Screening Service, which is the first line screening lab for Southeast region, and that's St. Thomas's Hospital. So every baby is screened for 9 different things. One aspect of it is for sickle cell and thalassemia. So the first center is St. Thomas's Hospital, where they will test the blood. And if they found the child to be affected, then they send it to another hospital, which is the King's College Hospital. King's College will now perform a second line and final testing and confirmation of the result. And this result again will come to us directly from King's College lab, and then we give the result to the parent. The result will come to us within 48 hours of them doing that. And we have to give the result to the parent by 5 days. We normally do a face-to-face result, and we don't give results on Fridays. The reason why we do face-to-face is because everybody is different. The way we perceive or receive information, not so good news information, is different. They might not have anybody at home to support them after we've gone. So we don't really give result. We call them to say, oh, I'm coming to see you tomorrow. I've got baby's result, or I'm coming to see you today. Sometimes you might say you're coming to see them tomorrow and they start panicking. They want you to give them the result. So what I tend to do is I call them on that day that I'm going to see them. So they know that, okay, I'm on my way. I'll see them in the next couple of hours. And on Fridays, we tend not to give them results on Friday because of the weekend break in between Friday and Monday. There's no one in the community to support them if they have any issues or questions to ask you. So we tend not to give them their result on Friday. And we send referrals to the Medical Center of Parental Choice for follow-up care. So I might see a baby delivered at St. Thomas's now, but the parents say, oh, I don't want St. Thomas's, I want to go to King's College Hospital. So it's their choice. We have to refer them to the hospital, and the babies must be seen by before 3 months of age, and they must be commenced on prophylactic penicillin by 3 months of age. That is the national standard. And now we have a database where the NHS England monitors every baby in the UK now. So if they are born, they want to know when they send the result to us, when we give the result to the parent, to make sure that we are working according to national guidelines, and where the baby has gone to, which hospital has the baby gone to, and the names of the patient, of the babies, and so on. So we have to make sure that we fill out the form correctly. Again, like I was mentioned earlier, that every baby must be seen and prescribed penicillin prophylactic by 3 months of age. It could be a day to 3 months. It could be on that day she's 3 months, or it could be three or 2 months before, but the baby must be on antibiotics by 3 months of age. And this is monitored closely by the NHS England. Follow-up appointment, we make sure that they attend every 3 to 4 months until they are 2 years of age, then 6 monthly. However, if they are taking some medication like the hydroxyurea, we tend to see them more often for blood tests and then clinic appointments, maybe every 2 to 3 months. Or if they have had stroke or at risk of having stroke, or they are always admitted into hospital, so we see them more frequently. Again, standard immunization and vaccination, special vaccination at 2 years of age, which is the pneumovax. That is given to them from 2 years of age and then every 5 yearly. And on top of this, we offer them flu vaccine as well during winter months, but this can be given to children 6 months and above. So if you have a baby now and they are born during winter, they won't be qualified until the next winter month. But we just encourage the parent to make sure that they look after them and keep them away from any viruses and infections. One of our key roles, again, is providing healthcare plan for schools. And I've done one already today. So every child going to school with sickle cell and thalassemia must have a care plan in place in school. For the school authority, or the school teachers, the class teachers, the school class attendants, to be aware of their condition and how they can support them in the classroom. Because some schools you might have few children in school with sickle cell, and it affects them differently. So if one is not sick all the time, the teacher might be wondering, but so is not sick all the time, and they might think, oh, it's because she doesn't want to learn or she doesn't want to come to school. That is why it's not like that. Even twins, they affect them differently. So we make sure every child in school with sickle cell and thalassemia have a care plan in school. And this is for preventative measures and for school to be able to administer medication like pain relief, because we want to keep them in school as much as possible. So we encourage parents to take pain relief like paracetamol, ibuprofen, and diadocodeine to school, while the school can give to the child. But the school needs to confirm from mom or the parent or the guardian when the child last had one, so that they don't overdose. Again, you find key emergency contact in there. My contact is on the care plan, the consultant in the hospitals, the CNS in the hospital, and the other key contact in case of an emergency from the family is on the care plan. And we review this yearly and update if required. And in the care plan is when to seek medical help. Parents are educated to recognize some potential complications of sickle cell early. So when we go home to see them to give the first result, that's why we don't encourage anybody else to give the result, like the health visitor, because sometimes the health visitors see the results before us. And if they mention it to the parent, they start panicking and they have loads of questions to ask. And this health visitor is not trained to answer those questions. So the parents start panicking. And imagine today, my clinic is very busy today. I might not be able to go out and do a home visit. And you have an emergency call, oh, so and so is very distressed. Can you go and do home visits? I might not be able to do that. And you can't leave them overnight without giving them the adequate information or support that they require. So we've made that mandatory for health visitors not to give the result unless it comes from Wooden Spoon House, which is our center. And because we have been trained to be able to deal with such situation if any arise. Again, is the child unwell? Things they need to look out for when the child is unwell. Is the child usually pale, especially in the retina? Is there any shortness of breath, and so on? And we do this almost daily basis. Like today, my role, I've done genetic counseling already today. I've already done care plan today. I've called antenatal women and give them appointments. So you can see we kind of multitasking. We do various things every day. So our day is not usually the same. It varies day to day, but it's now up to you to manage your care, your caseload properly. Do the priority. What are the priorities for us in our centers? Our priorities are the antenatals. Our priorities are the newborns. Our priorities are the ones that are very unwell, like those on care plan, level of care 3 and 2. And we encourage people to self-refer. I've seen a lot of women that for instance, they've had a baby before, they've been to our center before, and now they are pregnant again. They know they're at risk. and they want us to send them for the prenatal diagnosis testing. They don't wait at all for the hospital, for the GP, their local doctor to refer them to the hospital before coming to us. So we see them very early, and then because we've had them in the past, we have the information, they know what they want to do, they want to have the prenatal diagnosis testing. We just refer them to the hospital and await them to send us referral from the hospital. By doing this, we see them very early rather than very late. And again, people can get in touch with us via local screening programs, in our clinic or elder care professionals as well. So in case you have one or two queries or information you would like us to offer, this is where we are based. We are open Monday to Friday, 9 to 5, except on bank holidays. And this is our address and our telephone number and our generic email address. And this is the team. These are the team that cover the whole of Southeast London. Thank you. Any question?
Thank you, Kemi. As per usual, if you have any questions, either unmute yourself, put your camera on, ask a question yourself, or you can, if you want to, just put the question in the chat, and then I can present the question for you. But yeah, the floor's open for questions if there are any. Oh, Kemi, someone said very good presentation. Thank you.
Thank you.
Yeah, I've got a comment. Thank you, Kemi. It is very interesting to know more about the role of nursing all over the world with the sickle cell and thalassemia genetic counselling. It is very amazing that the care is it is really amazing, the care plan for every children with sickle cell and thalassemia at school. Just can you tell us more about the first level?
Okay, we encourage every child to have a care plan, but every country is different. Because of some countries like back in Africa, it's very difficult for you to have a care plan for them in school, as well as because they haven't had money to buy medication to support children in school who need support in school. So it's very, very difficult. I can't categorize different countries because it's different. But here in the UK, we try to make sure that every child has a care plan in school for the school to be able to support them in their education, learning, and so on. I think I've answered your question.
Thank you. If the question has been answered to your satisfaction, let me know. I can't see any hands up. I'll give it a few more minutes if there's any more questions or comments. Oh, have you got a question?
Thank you, Kemi. I just wanted to advance to the question, and thank you for answering our question. I think having a care plan. I think we have a framework of a care plan, isn't it? Did you share that framework?
Yes, so that I can share that.
Yeah, so that they can modify it according to their location.
I will email it to Ola now.
Yeah, but if you can show on the screen and probably talk it through. Then the other thing is is there any way that such a care plan can be modified to take into account what they have? So for example, like if you don't have money to buy the medicines, you also at least can have information about water, but also information to the school. So if you please share it.
Yeah, I'm bringing it up. I'm trying to see the one without a name on it.
I don't know whether I have some. I'll check. might have some if you don't.
I do have somewhere, but I just need to check to make sure.
There's no patient information.
Yes, there is no patient information on it yet. I think I have one now. It's loading. Yes. Okay, let me share the screen again. Can you see?
We see your folder with all the names of people.
Yes,
Not doing,
Uh,
not doing,
yes,
not
we
doing-
can see.
Stop sharing and then reshare.
Yeah, that's what I'm doing.
And then you have to double click so that we can see just the document.
Mm.
we can still see the same thing.
Is it coming up? It looks like something is happening.
It looks, we can see the
No.
folder with all the names.
Stop it and just close all your folders, Kemi.
Okay,
Close all your folders and then open that document only before
All
you
right.
start sharing.
If it's easy, you can send it to me and I'll try.
Stop sharing. Click to stop sharing.
yeah, I have.
No, you're not. You haven't.
But I have.
We
I
can still
clicked on
see it.
Stop
No,
share.
Kemi,
Okay, yeah, we go.
you've just stopped now. Well done.
Is it
Stop.
on the screen?
It's now just gone up. So can you forward it to Ola and she can share it for you, please?
Okay, I'll forward it now.
Thank you.
Yes, hello. Can you hear me?
I can hear you.
Go on.
Yeah.
Yeah. Thank you for amazing lecture that you just tell us about. I'm just wondering about the school care for the thalassemia patient or the sickle cell student. I mean, how the obstacles that you face. Some story about, can you give us some story about that you're facing, how you can cooperate and manage cases in school? What is the most important problem that facing you in caring those patients?
Yeah, that's the reason why we do a school care plan, for the school to know exactly when to take action. For instance, inform the doctors or call the ambulance for the child if they are having difficulty breathing, or if they are not feeling well, if they are complaining of chest pain, if there are, signs of stroke and so on. So that's why we do health promotion in school as well. We go to school. I normally go to school to see that, sorry, let me just end this, that the school is aware of the child's condition and they are able to support the child in school if there is any problem in school. Yeah, I've sent it to you, Ola.
Thank you. I've just seen it.
Yes, you mean your role is as a school nurse going to the same problem reported to you as we have in Saudi Arabia. As our role as a school nurse, we go to any report about a problem coming to us about, for example, another diseases, not just for the thalassemia or sickle cell. I'm just want to see the
Go down, let's see.
the difference. Now
Yes.
you can in this screen you can more explain. Thank you.
Yeah, every school also have a school nurse. So if they're having issues in school, usually they inform the school nurse before us, unless it's sickle cell related. And then they will give us a call to find out what they need to do, if they need to take the child to the hospital or call the parents or administer medication in school for the child. But there is a school nurse apart from us in the school.
Okay, Kerry, you can let me know if you want to scroll down.
Okay, you can see the care plan now. So this is what the care plan look like. Every child with sickle cell and thalassemia, we fill out the first bit and all the information that they need, like the consultants, the doctors they are under, the hospital where they are going for their follow-up care. My name is there, and one of the hospital nurses, I forgot to remove that name now, she's no longer there, and one of the doctors is no longer there as well. So this is what the care plan looks like, and is what we use across Southeast London. And you can see all the information, what sickle cell is, daily requirement for the prevention of symptoms. So you can see the first point, to prevent dash dash, is the name of the child that we will fill in there. Yeah, the name of the child, we'll put the name of the child in there. Or if it's a he or a she, then we change it accordingly. Okay, and again, extreme change in temperature, what they need to avoid. So this is a lengthy information for the school officials to know more about sickle cell and how they can deal with it in school and support the child. So you can see, and you can see when should an ambulance be called. So you can see if the child is suffering from increasingly severe pain, high fever and looks ill, appears exceedingly drowsy, that might be stroke, has a severe headache or develop weakness, stroke, becomes confused, disorientated, or notice a lapse in concentration, it might be stroke as well, has difficulty in speaking, breathlessness, complaints of chest pain, dial 999 for ambulance and call mother. So the mom information and other contact person is on the care plan. For instance, if they are trying to get hold of the mom, and maybe what mommy is working, and in our workplace, they are not allowed to use phone. So mommy might not know that they've been calling her. So that is why we make sure that we get another contact person in the family, and they can then maybe come to school to pick the child up or meet them at the hospital. And we also put medications that this child is taking at home and which can be taken in school. And this needs to be prescribed by the doctors with the pharmacy label on it. Without the pharmacy label, we don't encourage school to administer such drug. So every pain relief for every child must have a pharmacy label with the child's name, the type of medication, the frequency of dosage of administering, and the dosage on the box or for the child. Without it, the school is not allowed to give the medication. And so you can see when they need to call mom and so on. So once we finish writing this care plan, I will sign it, agree it with mom as well as the school, and we date it, and it's kept in the child's folder in school. So every time they are concerned of any issue, it's like a reference guide. They can just go there and see it, so they know who to call, what they need to do next. And on the next page is the pain ladder for the child. It's like pain chart for the child. So the child's name is there, and you can see that the severity of the pain, by looking at the picture, you can tell that, oh, the child is, the pain is 6 to 7 or 4 to 7, something like that. So we need to give medication and so on. So you can see that. And this is what the school use before they call the parent, and maybe before they administer pain relief in school. I think that answers your questions.
Yeah. So and I think the other thing which you do also is if you think about some specific situations, because we know that the child who is drinking more water has sickle cell disease, is likely
Yes.
going to require to go to the toilet more
Yes,
often.
that one, I have another care plan for that as well. Let me see
Okay.
if I can share that from one of my,
Okay, maybe
that one,
if you have it, you can forward it to Ola again,
I will
so that we
do
don't see
that
your
now.
screen.
Yeah, I will do that now. It will be at the end of this presentation I'm sending to Ola, so Ola can see that, yeah, and then give it to.
Yes, thank you. Ola, can you please send it and share it for us? It's
Of course.
very amazing thing. Yeah, thank you.
I'll
Thank you.
send it to Mohammed, and they can
Okay.
send to everyone else.
The care plan, you can check from page 22. I'm sending it to you now. The previous one, you can see from page 22, yeah?
Yes, my dear, I just want to know also about the algorithms that you show us. Some of the algorithm it's needed for us. We want to know how we can make the decision, what is the arrow go, where is we can in our system many division. So we want to modify this also for us. It's very benefit.
Yeah, I'm happy for Ola to share that. So Ola can share that to whoever needs it.
And I think probably going forward, we're hoping that we'll be able to have some partnership with you, so that we can work on some of these things together and see what works for you, and then we can share the lessons.
Yeah, Ola, I've emailed it to you.
So Ola, you click slideshow from page 22, slideshow. That's good.
Yeah.
Next.
So this is another way that the parents, we also encourage them in school when we do the health promotion, that we encourage every child to have a water bottle, to drink water while in
Next
class.
slide, Ola.
Yeah, because some schools don't allow children to drink water during lessons, but it's different for children with sickle cell and adults with sickle cell. So we encourage them to have their own water bottle and drink as much as possible in class or in school. And you know, when you drink plenty of water, you need to go to the toilet. And that's the difficulty some of our children faces in school, particularly in the secondary school age. They find that very difficult because they won't let them go to use the toilet. So we speak to the school office. Sometimes they give them a pass. So once they show the pass up to the class teacher, they need to excuse themselves for maybe pain relief, to go to the school office or medical office, or to use the toilet or something. So we encourage them to have the pass, because you know, children with sickle cell, their kidney don't function properly and they cannot hold the urine. So if they need to go, they need to go. So we let the school know that if they want to go to the toilet to wee, they should please allow them to go to the toilet. And swimming is another problem that most parents faces. Yeah, because some parents will say, oh, every time he or she go for swimming lessons, by the time they come back, she's gonna have crisis. And they don't want the child to have any swimming lessons at all in school. But we encourage every child again to learn how to swim, because it will be very good for them whenever they get into any difficulty. But what we encourage them is, when they go to the swimming, the pool must be checked by an adult to know that the pool is warm. And when the child goes in the pool, should not come out, should stay throughout the lessons in the pool, because in and out can trigger crisis, extreme change in temperature. So we encourage the child to stay in the pool for the duration of the lessons. And when the child come out of the pool, there is an adult to dry the child very well and wear dry clothing for the child. By that, the child can participate with his peers and enjoy swimming. And we've seen that reduces crisis by doing that. Again, we don't discourage them from cross-country activities. We encourage them to do as much as they can, but they need to learn to know their limits. They need to learn to know when to stop, to rest, and so on. They will also be having days off school. And that is one of the things in the care plan as well. Maybe for hospital appointment, maybe when they are not feeling well, or maybe when they are going for their blood transfusion. So they will be missing school more than any child without any long-term medical condition. And sometimes some school provide a corner in the class when the child is tired and sleepy, and they've noticed that it's not stroke or anything. They just put the child in a corner on a beanie so that the child can rest for maybe 10, 15 minutes, and whenever he or she feels better, they can join back in school. So those are the things that we mention when we go to school to do health promotion for them.
Thank you. Does anyone else, any other questions? Okay, if there's no other questions and no other comments, I would like to conclude that as the lecture today. Thank you so much, Kemi, for doing this and
You're
for
welcome.
the lecture. I think everyone found it very informative. Again, if you have any more questions, you can put it in a Slido and I'll pass over to Kemi. She can answer it later.
I'm
And
happy to do that, yeah.
And I will send over the documents to the team I'm in contact with and they can disseminate to everyone else. I hope you have a lovely evening.
Thanks, Ola. I appreciate it.
No worries. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thanks, Kemi.
Bye.
Have a nice evening.
You too.